So, good evening, friends. We start with the session, and I invite our moderator, Dr. Sharda ma'am, and the experts for today, Dr. Bhasker, Dr. Jyoti Agarwal, Dr. Poonam Goyal, Dr. Raj Bokaria, Dr. Anita Rajoria, Dr. Leena Sreedhar, Dr. Mamta Mittal, Dr. Seema Sehgal, and Dr. Achala Batra. So I can see many of the experts have joined. However, some I think will be joining soon. So it is going to be a fantastic session. Our speaker today is none other than Dr. Krishna Gopal. We've heard him so many times before. Dr. Sab is MD Radio Diagnosis and also Director of Advanced Diagnostics at Ghaziabad. So actually I'm on my phone and the laptop से नहीं join कर पा रही हूँ इसलिए phone पे हूँ. So without wasting much time, I invite Dr. Krishna Gopal. He'll be talking on fetal growth retardation made super easy, and how do we manage that with the help of ultrasound?
See, the topics are made by me. In fact, Dr. Gopal may be feeling uncomfortable about it, but I think, such a learned person who is a mix of both fetal medicine expert and an super easy. He should not only concentrate when he's making a presentation today for A-grade city, but he should also consider gynecologists and self-styled gynecologists who do not have a postgraduate degree when they are managing such cases and they give wrong. Because as an expert of DMC and as NMC in the last 18 years, I've realized that nearly 15% litigations are only for this. Borderline growth retardation है और उससे 2 किलो का बच्चा है, कोई बात नहीं, इंडक्शन करते और बच्चा गया. So I think let's hear the expert Dr. Gopal how he's going to make the presentations and make it super easy.
Thanks, ma'am. And when it comes to making it super easy, it is a huge responsibility actually. So I have just put the fundas in my presentation without much of the details. So I'm not going to bore you with the physics of Doppler or the nitty gritty of the stuff that bored you actually. I will just give you the funda for your day-to-day practice. So the topic is that role of obstetric Doppler in diagnosis and management of FGR. So obstetric Doppler has a role both in the diagnosis as well as the management of FGR. So by definition, fetal growth restriction is the fetus failing to reach its genetically predetermined growth potential. But problem is that fetal growth cannot be assessed through a single biometric evaluation of the fetal size, and the concept of growth potential is purely hypothetical. So how to diagnose fetal growth restriction? So when a fetus comes to you and you see that abdominal circumference or effective fetal birth weight is less than 3rd centile. Now, most of you ask what is centile. So I again want to go in the details of the physics of the centile. It is there in every machine. If you see this worksheet, so effective fetal weight is 19.3 centile and AC is less than 2.3 centile. So it is less than 3rd centile. So you can easily say that the fetus is fetal growth restricted. Similarly, this is a chart where there are 3 curves. First is 90th centile, 50th and 10th. So if effective fetal weight is less than 10th centile, so we can see there. But we can diagnose FGR in a single instance when AC or effective fetal weight is below 3rd centile. There is another way when there is a drop in the fetal growth velocity for two quartiles. one is the 25th, so more than 50th. In easy form, if I have taken AC and it is at the 70th percentile, and in the next instance, if it is below 20th centile, then we can consider it as FGR. So we can diagnose FGR in this way, and there is a one way. But fetal growth is a dynamic process, and it requires multiple observations of fetal size by the biological parameters over a period of the time. So these biological parameters may be CRL or BPD, SC, AC, or FL, or the effective fetal weight. So, but the problem is that each biological parameter has its own biological variability. This is least with the CRL, that is only 3 to 5 days. That is why dating scan is the most important scan for determination of the fetal age. So the first step is assigning a gestational age. So the dating scan is the most important scan. Once EDD has been assigned, do not change it in the subsequent scan. Relate the subsequent scan to the corrected EDD. So whosoever is doing the first scan and measuring CRL, that operator must write EDD, so that next operator, whosoever is seeing that same fetus, can correlate with that EDD for the particular gestational age. So once EDD has been assigned, never change it in the subsequent scan. If patient visit you first time and have doubt, calculate gestation age by EDD derived from the dating scan. Many times patient आता है कहता है कि सर पहले तो जिन डॉक्टर ने किया था उन्होंने हर अल्ट्रासाउंड में EDD लिखा, आपने EDD क्यों नहीं लिखा? तो it is our duty to make the patient understand that EDD is just being given in the dating scan, and if the dating scan has been missed, then in the second scan. Role of multi-vessel Doppler is for the diagnostic markers. It helps in identifying FGR to differentiate between the early and late FGR and SGA, and as well as in helping in the triggering preterm delivery, that is the delivery before 37 weeks. Vessel, you should know, not in detail. You should just know that uterine artery represents materno-placental compartment. That is, it is the main supplier of the placenta. So if there is any issue with the uterine artery, this will lead to the dysfunction in the placental, in the placenta, like in the cases of preeclampsia. Umbilical artery basically represents feto-placental compartment. That is, if there is a placental dysfunction, it will show changes in the umbilical artery. And MCA, ductus venosus and the aortic stomach are purely fetal vessels, so they show the changes in relation to the placental dysfunction. So जब भी placental dysfunction हुआ, umbilical artery में changes हुआ, so then what are the compensatory mechanism happens in the body of the fetus. So these changes are reflected in these fetal vessels. So these are the basic concept. Second thing is that we should not go for anything. अभी भी लोग पूछते हैं कि सर PI तो आपने बता दिया, S/D ratio क्या है ये बताइए. तो PI is the most acceptable and it shows linear relationship with the vascular resistance and it does not approach infinity. मतलब if S/D ratio has been taken as a Doppler index and if diastolic value will go down to 0, then the value will approach to the infinity. That is not possible. So that is why PI is the most acceptable Doppler indices and it should be used through everything other than PI out of the window. It is not needed. Secondly, the basic concept is whenever the vascular resistance, PI will go up, that is PI will rise, then diastolic flow will reduces, and when PI will be low, PI will fall, then diastolic flow will increases. As in cases of uterine artery, with the advancing gestation age, to fulfill the increasing demand of the fetus, the diastolic flow increases. So the PI will fall gradually throughout the gestation age, and then it gives the increased supply to the uterus as well as in turn to the fetus. But in the abnormal situation, the PI will increase and diastolic flow will goes down as with the progressing gestation age, and this is associated with the poor perinatal outcome and increased risk of the maternal preeclampsia. Similarly, umbilical artery, which is actually a fetal compartment, that is feto-placental compartment indicator vessel, it is used in the surveillance. But the problem is that these changes occur lately. Like if the 30% of the villus damage happens, only then we have a high pulsatility index in the umbilical artery, and absent end diastolic flow stages when the 60% of the villus damage, and when the 70% of the villus damage happens, then we see the reverse end diastolic flow. So, and middle, the cerebral artery, when umbilical artery PI increases, that is the vascular resistance rises, then it automatically causes the vasodilatation in the middle cerebral artery, resulting into fall in the vascular resistance, that is PI, and increase in the diastolic flow. So that is why middle cerebral artery is indicative of fetal hypoxia. But the CPR, that is cerebroplacental ratio, shows these changes much earlier. How? Because if you see that CPR is actually the ratio of MCA by PI, MCA by PI of the umbilical artery. So if the MC is normal and the changes are only confined to the umbilical artery in the early stages, only in that circumstances also CPR will be abnormal. So CPR becomes abnormal even before MCA. That is actually assessment of the fetal cardiac status. So in cases of fetal vascular resistance increase, heart has to pump against the increase afterload. So slowly heart first compensated and then heart started failing down. So this is shown by the raised PI in the ductus venosus, and afterward there is absence or the reversal of A wave in the ductus venosus. A wave is basically atrial contraction. So as you see, first there is a presence of A wave. The A wave is slowly showing its absence, and then it shows its reversal. So it is the stage of acidosis. Aortic isthmus is not much used, but is thought to show the changes of ductus venosus much earlier, because basically aortic isthmus is actually representative of both the right ventricular outflow and the left. So the right is actually shows the placental side, and the left is the fetal side. So any changes in the either on the placental side or on the fetal side is shown in the aortic isthmus, and it helps to predict the perinatal morbidity and morbidity. Small for gestation age is the fetus when its size, that is the biometric evaluation, falls below a predefined threshold for its gestational age, that is effective fetal weight, or AC less than 10 centile for a given reference range. So the pinch here is the predefined threshold and the given reference range. So many people debate that whether standard charts are good or the customized charts are good. Don't go into controversy. The Hadlock 3 present in most of the machine here is well correspond with that of the Indian population. So if you have diagnosed SGA baby or FGR baby in Hadlock 3, it will correspond with the Indian population. So don't go into any controversy. So now we have a small fetus, that is effective fetal weight less than 10 centile. So first thing I will see that whether dating is correct or not first. Second, we will exclude primary defect and the expensive cows, that is whether the baby is associated with any congenital defect or not, and then it is an isolated small fetus. Now our job is to differentiate between the FGR and SGA, because FGR is associated with the poor perinatal outcome and intrauterine fetal death, and we should not prolong the pregnancy beyond 37 weeks. So it has to be differentiated by, again, the proper signs of adaptations. What are they? That we will discuss later. Another entity, two different entities with different pathophysiologies are early and late onset FGR that must be differentiated. The first question that comes in the mind, that how early is early onset and how late is the late onset FGR. So any FGR diagnosed before 32 weeks is the early onset FGR, and the FGR diagnosed after 32 weeks is the late onset FGR. These are important to differentiate because of the different management, different outcome, and different pathophysiology. So the idea is that early onset FGR happens when more than 30% of the placenta is involved. So fetus is deprived of both nutrition as well as the oxygen supply since the beginning. So fetus is smaller in size and is quite adaptive. So the peripheral circulation get adapted. Heart is getting adapted since the beginning. That is why there are chances of the failing heart later on. That is why we see the changes in the DV. And late onset FGR is when the less than 30% of the placenta is involved. So the fetus goes to its near normal size or to some extent, and the nutrition and oxygen supply hampers only when the fetus grows to a certain size and its demand increases. So now we have a good grown baby. Now its demand increases. So these fetuses their hearts are well developed. So we are not concerned with the DV. We are concerned with the hypoxia. So that is why we see the changes in the CPR. Now, internationally, Delphi consensus is the way to differentiate early FGR and late FGR. But this is what the guideline give you the picture of Delphi consensus, and that is the busy slide. So I have made it very simple for you again. So if you are seeing an AC third centile, my first or second slide I have shown you. So if you are seeing on the single instance AC third centile or effective weight third centile in less than 32 weeks, this is early FGR. If you are seeing AC and effective fetal weight third centile after 32 weeks, it is late FGR. If you are seeing absent end diastolic flow in the umbilical artery before 32 weeks, it is early FGR. Or if you are seeing AC or effective fetal weight less than 10 centile in conjunction with umbilical artery or uterine artery PI more than 95th centile before 32 weeks, it goes in favor of early FGR. And if you are seeing AC or effective fetal weight less than the third centile or the crossing centile of the two quartile with CPR less than fifth centile. So this is the suggestive of late FGR. You can take a picture of this slide for your day-to-day practice. Now I have made one simple algorithm that if there is a less than 10 centile fetus, and if umbilical artery is abnormal, then it goes in favor of early FGR. If umbilical artery is normal, we will do uterine artery, MCA, CPR, and effective fetal weight third centile. If either of these is abnormal, then it goes in favor of late onset FGR, and if these are normal, then it favors SGA. Another the topic that is much in the fashion to discuss is AGA fetus, that is appropriate for gestational age fetus. The story starts when one of the paper from Netherlands published that the fetuses between the 10th and 50th centile need also our concern, because these fetuses also shows signs of FGR and has poor outcome. So basically AGA fetuses are those group between the 50th centile and the 10th centile. So till the most workers of the world has agreed that AGA fetuses should be managed as late onset FGR. We should look for the brain sparing and MCA. CPR holds the key, and we should also look for the drop in the growth velocity. Now we have made the diagnosis. We have categorized them in small for gestational age, appropriate for gestational age, early onset and late onset. But now how to manage them? So early onset FGR has a severe placental disease. So there is a severe hypoxia since the beginning, as I told you. MCA will always be compensated, so it has a no clinical utility, and trigger is the acidosis, and delivery is entirely on the ductus flow or severe umbilical flow. So here we have to see for the ductus flow. Late onset FGR, MCA is predictor of adverse outcome, but become abnormal very late. CPR become abnormal early, so it is the best tool for surveillance. Hypoxia is a trigger, and here heart is not compromised as that of the early onset FGR. So lately, ISWAP guideline has been published in 2020 for the management of the early onset FGR and late onset FGR. So this is a busy slide, and I will make it simple for you. So if we will go for the active management of the early onset FGR, then we should see the late ductus venosus Doppler changes in the form of A wave at or below the baseline, or the umbilical artery Doppler changes that is more than 32 weeks or reverse end diastolic flow. And if it is more than 34 weeks, then we will look for absent end diastolic flow. As far as late onset FGR, this guideline says that no international consensus on the timing of delivery in late FGR due to the lack of interventional management randomized trials based on the Doppler indices in this pregnancy, and national guidelines are also valid. That is why our favorite is Barcelona staging based management. It is a simple algorithmic approach common for both early onset and late onset FGR, and very easy to follow in our day-to-day plan. So what are these staging? So stage 1 is when there is a mild placental resistance or redistribution stage. So we will look for the CPR value less than 5th centile, uterine artery more than 95th centile, or MCA less than 5th centile. So if these changes are there, so it is a stage 1, that is low mild placental resistance. Stage 2 is severe placental resistance, when we will see absent end diastolic flow in the umbilical artery, or if somebody is doing aortic isthmus, then PI more than 95th centile. Stage 3 is severe hemodynamic adaptation, when there the ductus venosus PI is more than 95th centile, and there is a reverse end diastolic flow in umbilical artery. And stage 4 is when there is a wave reversal in the ductus venosus. So depending upon this staging, we can do the follow-up as well as the management decision, delivery decision. So if we have diagnosed one fetus in stage 1, and if it is 37 weeks, then we should not hesitate and deliver the baby. And if it is not 37 weeks, then we should do the weekly monitoring. And if it is still in the stage 1, then we will wait till the 37 weeks to get it delivered. If we have diagnosed stage 2, then, and if it is 34 weeks, then we should go for cesarean section straightforward. And if it is not, then we will do the monitoring by week. And if it is stage 3, and if it is 30 weeks, then we should do the cesarean section straight away. And if it is not 30 weeks, then we should do the monitoring 1 to 2 days. And if it is stage 4, then, and if it is 26 weeks even, then we should do the cesarean section. And if it is not even 26 weeks, then we should do the 12-hour monitoring. So the thing is that whether it is early onset FGR or if it is late onset FGR, if you are seeing umbilical artery end diastolic flow, and even if DB is not involved, then, and if it is 34 weeks, then you should deliver the baby by cesarean section without any hesitation. Let not the baby go to the stage of acidosis. There is no point, because that is how this carcinoma staging says. So let's see how it works. Like in this case, so she is 37 weeks already, and on Doppler the parameters we are seeing PI umbilical artery more than 95th centile, PI MCA less than 5th centile, CPR was abnormal but ductus was spared. So it was a stage 1 and it was already 37 weeks, so we will deliver the baby. Similarly, in another the case, if it is 33 weeks 2 days, and here not only the CPR was involved, rather than ductus venosus also showing reversal of A wave, then it is already stage 4, and since we have crossed the 26 weeks parameter, so we will do the cesarean section straight away. Amniotic fluid has no role, and it is stable for 8 weeks, and it is chronic variable, and there is no longitudinal progression. Reduced fetal movements are rare according to the workers, because 55% women experience it before birth, majority preceded it with 3 to 4 days. There are no fixed number, each fetus has its own pattern. Trust mother more than 2 episode put on the high risk surveillance. Biophysical scoring has a role by the ISWAG guideline, because computerized CTG are not much there in India. So in absence of computerized CTG, Doppler evaluation, conventional CTG and biophysical scoring should be performed. Loss of fetal gross body movement with ductus flow changes, the fetal cord is less than 7.20, and loss of fetal tone with ductus flow alteration, fetal cord pH less than 7. That is what of the guidelines. Practice is either the degree of normal or any abnormal Doppler, then we can easily counsel the patient. The take-home messages are that dating scan is the most important. So never miss the dating scan. When in doubt, always calculate gestation age from EDD derived from the dating scan. Always ask your ultrasound operator to give the effective fetal weight and AC in centile. Categorize FGR in early onset and late onset. I here request you to consider the advice of Doppler around 30 to 31 weeks, because if at that time we will see the Doppler changes, then we can easily categorize between the early onset and late onset. Suppose after your anomaly scan advice, if you will advise the fetus at say 36 weeks of Doppler, then we will find it difficult to differentiate between early onset and late onset. DV and CPR are the most important indices in the early onset and late onset FGR, and Barcelona staging is the key for management of FGR. In our set of practice, I don't advise always. Some people say that we are doing just because of the Krishna Gopal's indication, but Krishna Gopal always advise that don't let baby to go in the stages of acidosis first, and second is यदि बच्चा बाहर आ गया तब तो आप उसको कुछ भी कर सकते हो, अंदर तो आप उसका कुछ भी नहीं कर सकते. So it is always safe than sorry, if you are seeing that it is 35 weeks and CPR is abnormal, don't wait till your DV changes if it is a stage 2. Thank you so much for all your attention, and all the questions are invited.
I think Dr. Gopal, you've done an excellent presentation. Now I will open it up with, for comments from the experts. We will also oversimplify it, so we will take one by one. We start with Dr. Poonam, Dr. Jyoti. You want to make any comment before we throw it open to all clinicians?
Yes, ma'am. I'll make it further more simple. Dr. Krishna Gopal has done a wonderful job. बहुत ही simple और बहुत ही सीधा समझा दिया है सब कुछ. फिर भी उसको दोबारा से दिमाग में रखने के लिए कि so that you don't need to see the slide, जो सर कह रहे थे कि slide की फोटो ले लो, उसकी भी जरूरत नहीं पड़ेगी. What you have to do, पहली बार जब आपके पास में patient scan लेके आ रहा है, in first trimester you have to fix her LMP and EDD. Yeah, so you have to just underline it and tell the patient also and write it on the paper her EDD, so that does not change. First thing is that. Then the second thing is if your everything is going all right, then you need the scan between 30 to 31 weeks, that is growth scan. No growth scan is without Doppler. You should, if your radiologist does not understand that growth scan needs Doppler, then you have to write Doppler scan at 31 weeks. Otherwise, it is growth scan. Then in the Doppler scan, what you have to see majorly 4 vessels: uterines, umbilical, MCA and DV. Your umbilical artery should have a PI of less than 1, it will be around 1 at 30 to 32 weeks, but as the gestation goes on, it will start decreasing, it will become less than 1. And the PI of MCA will be around 1.5. वो 1.5 होगा, वो 1 होगा, तो आपका जो CPR है, that will always be more than 1. So earlier we used to take it as more than 1, but now we take it in centiles. So another thing is your radiologist should give you report in centiles. Nothing less than centiles is acceptable. And then the management Barcelona protocol is the best for the management. That is the best for the management and best to understand. And whenever there is any doubt, then you take out those graphs from the Google and then plot the graphs and give it in the report also to the patient. And then you can see whether this is going a SGA fetus or it is going actually FGR fetus.
Dr. Poonam, this in Barcelona thing, you said the PI of uterine umbilical artery more than 95, less than 5. ये भी explain करो इन लोगों को.
Yes, ma'am. PI of umbilical artery, if it is more than 95 centile, that simply means there is resistance in flow in the umbilical artery. So to adjust accordingly, the fetus will have MCA redistribution, and in the MCA, the centiles will be less than 5%. So that's it. Now, that means your things are going topsy-turvy, umbilical is increasing and MCA is decreasing. And when this happens, obviously your cerebroplacental ratio will also change and it will come less than 5 centile.
Plus simply ये वाली बात है, जब भी resistance होगा, supply कम होगी, तो nature takes phenomenon. MCA में पहले blood supply बढ़ेगी और बाद में कम होगी. So this is what one has to understand, and this is what the play is 95 and 5. Dr. Jyoti, you want to make any comment before we go on to the other experts? You have to unmute yourself. Yes.
Thank you, Dr. Gopal, for a wonderful and an oversimplified presentation, and quite a brief one also. Dr. Poonam has further simplified it, and nothing much is left for me. But here I would just like to tell you, in fact, not even 4 vessels for IUGR, 3 vessels are good enough. Uterine artery is more important for maternal diseases like PIH or the predictors. If we are dealing with an IUGR baby, we need not do the uterine artery. Don't waste time in doing uterine artery. हमें arterial changes देखने, उनको venous changes देखने. As far as there are no venous changes, आप मान के चलिए patient baby is only hypoxic, not acidemic. जब venous changes आने शुरू हो जाएंगे तब baby acidemic होता है, impending cardiac failure and death होता है, जिसके लिए ductus venosus is the most important thing. And in a preterm IUGR, if we are delivering a preterm IUGR, we have to go by the guidelines of ductus venosus. And at any cost, an IUGR baby should not be allowed to go beyond completed 37 weeks, even if the Doppler is normal. We should deliver at completed 37 weeks, not to take any risk. And Doppler normal hai, and there are no changes in the diastolic flow of the umbilical artery. We can repeat after 2 weeks to see for the follow-up. But if there are changes, moderate changes, then we may have to do it bi-weekly. And suppose there are much more changes even in the venous thing, then we may have to do it after 1 to 2 days. And here I would also like to stress that the biophysical scoring, which we usually gynecologists say कि आप biophysical score करा लो, NST करा लो, all these changes come almost 2 weeks later than the Doppler. So Doppler is more important than the biophysical scoring. And at the same time, Doppler has no role for normal fetuses who are not at risk. That means normal pregnancy. It is only to be done when the fetus is at risk. This is what I just wanted to add.
I think it's 3 experts have really oversimplified everything. I would like the other experts to make a comment from the clinical point of view. What they find day in, day out in your practice. Dr. Gopal, you have to comment on ductus venosus. उस ductus venosus के changes के लिए wait नहीं करना है.
बिल्कुल वेट नहीं करना है. CPR यदि आपका abnormal है और आप यदि डायग्नोज कर रहे हैं स्टेज 2 में भी, तो आपको निकाल देंगे. Any clinical comment?
Dr. Jyoti Bhaskar, Dr. Anita Rajoria.
Yes, ma'am, I just want to say that of course we will not wait for the ductus venosus changes to happen, but we should, as a clinician, we must remember that 1 day in utero means 3 days in NICU. So we want to buy some kind, especially in preterm babies. So in those cases, ductus venosus thereby remains the main factor which will determine when to terminate pregnancy, as Dr. Gopal has very well highlighted. So we have to be very careful, but we have to buy 1 or 2 days. So we can wait, and then we can accordingly, depending on ductus venosus, if we find that changes are happening, we have to terminate this pregnancy. And as Jyoti ma'am has also highlighted, that the more severe the changes, closer monitoring we have to do, and we may be needing, the patient may need to be admitted for safe confinement in these cases for closer monitoring.
I just want to know from Dr. Gopal, LICAR has no role in with IUGR babies, whether with IUGR or as an independent parameter. I would like to know from the other experts who we have seen in our practice. Usually, when है, IUGR सभी कुछ कम होता है, पानी भी उनका कम ही होता है, 7.58 पे चल रहा होता है. And another important thing I would like to know, what about the placental prematurity? The aging of the placenta, the changes with the grade 3 and calcification, seen normally at 40 weeks, we start seeing at 34, 35 weeks. Is there any significance? What does the expert say, and Dr. Gopal?
I think before we go on to Dr. Gopal, I like to hear from the clinician as for the amniotic fluid index is concerned, how much weightage they give. As a clinician,
I give weightage. I give weightage.
I also give weightage. Both the guidelines say it has no role, but I give weightage. And we have seen.
I give a lot of weightage on it, and I think beside Doppler, my decision for termination depends on, in spite of the low molecular weight heparin, if things are not increasing for her, I definitely go on AFI. Anybody wants to make any comment? Dr. Jyoti Bhaskar, Dr. Umar, Madam Raj, you want to make any comment on the role of AFI on day-to-day management?
Can I say something, ma'am?
Please.
Up to 5 centimeter of the amniotic fluid, at least I can wait.
We take it usually 6 as a
One single pocket of 2 centimeter. Up to 2 centimeter, even once, and total is about 5 centimeter.
We take it as 6 usually.
Ma'am, unmute karna.
All around. You have to see all around, including the Doppler flow, even every day, it repeated every third day or weekly. And let us reach the gestational age where we can safely give the hope to the patient. And it all depends upon your NICU facility also.
Madam, unmute.
Ma'am,
unmute करिए.
What is your cutoff? My cutoff is 6. I don't for them go down.
Any other comment?
Traditional teaching has been 5 to 25, so I wait up to 5. So we can wait
I
for a
also
day.
keep 5.
I also wait for 5.
I think it is personal thing, depends upon
Yeah, I just
what
wanted
things
to-
are. But people like me, when we find, I think every patient also takes one particular day, for decision to make. One should play a safe game.
And here I would also like to I'd like to say that those who are doing ultrasound, before even going to the Doppler, if you see good fetal movements, if you see thumb sucking, yawning and things, these are the finer activities of the baby. If these are normal, आप मान के चलो उसका Doppler भी सही हो.
Ma'am, I will like Dr. Gopal to answer how much importance does he give to hydration of patient, ma'am? Regarding AFI calculation, how much importance he gives to adequate hydration of patient? Yeah.
Done.
That's what I am trying to say. The slide says that isolated AFI doesn't have any role. That means.
Sir, we clinicians are not talking in isolation. We are not talking in isolation.
Yes.
We are having a discussion on a Doppler and calling you as an expert. We are not taking anything in isolation. But I'm telling you is that if you will commit a disaster, as an elder I can tell you will commit a disaster if you keep on waiting for the FI to go down.
That's
Dr. Poonam, what do you have to say? You are a clinician as well as an ultrasound expert.
Ma'am, I think lighter is very important. With Doppler, if the things are going wrong and the lighter is less, then it becomes very important to terminate the pregnancy. And one thing which I feel is it is very easy to explain to the patient when lighter is not there. बाकी चीजें तो समझाते रह जाओ, दिमाग खराब हो जाता है. पानी नहीं है, 1 मिनट में समझ में आ जाता है.
I fully agree with you.
Yes.
Dr. Poonam,
Simplify.
Yes, doctor. Please, everybody mute themselves. Let Gopal say.
Yeah. See, actually, there are cases in which we see that the liker is normal. Okay. But still, if Doppler has changes, then we should not wait for the liker to go down. That's what I am trying to say.
Understandable. We are taking cutoff is when the liker is low. When the liker is 4 and Dr. Jyoti says डॉपलर इज ओके तो 4 में बैठे नहीं रहना,
नहीं बैठे रहना, एग्जैक्टली
बैठे नहीं रहना.
डॉक्टर गोपाल, ये
Time and again. See, I'm not talking about the government hospitals because वहाँ पर तो responsibility है नहीं. Private sector में 1 करोड़ लगेगा डॉक्टर साहब. तो अनिता की बात नहीं सुनना.
डॉक्टर गोपाल, मैं ये
रिस्पॉन्सिबिलिटी नहीं है, पर आपको 1 करोड़ देना पड़ेगा डॉक्टर साहब.
हाँ मैम, मैं वही कह रही हूँ, 5 सेंटीमीटर तक हम वेट करते हैं, लोअर लिमिट 5 तक. उसके बाद तो नेचुरली हमारे भी ट्रिगर ऑन हो जाता है, हम पेशेंट को इंड्यूस करते हैं या इलेक्टिव सिजेरियन करेंगे ही करेंगे. मैं डॉक्टर गोपाल से ये जानना चाहती थी कि अगर हाइड्रेशन का कितना इंपॉर्टेंट है, मैटरनल हाइड्रेशन का AFI में आपने देखा है कोई फर्क पड़ता है?
नहीं मैम.
भैया जरा डॉक्टर पूनम और डॉक्टर ज्योति उसको बता दो, अगर पेशेंट
नहीं मैम, नहीं, ऐसा कोई फर्क नहीं पड़ता हाइड्रेशन का, ऐसा कोई फर्क नहीं है
मैडम.
नहीं पड़ता है.
लोगों को ये मिसकंसेप्शन है लोगों को. यस मैम, दैट इज द थिंग. यस, मिसकंसेप्शन है लोगों को ये.
पहला क्वेश्चन पेशेंट यही पूछती है कि अच्छा वो कल से पानी कम पी रही थी इसलिए
यस डेफिनेटली.
ऐसा नहीं होना चाहिए.
और मैंने देखा है कि कुछ ऑब्स्टेट्रिशियंस दे विल पुट पेशेंट ऑन IV fluid, ये this then that. I think this is not the way to handle the patient. That is the message I wanted to convey, that we should not be blinded by this hydration concept. We should not give it.
Now we come down the management. Dr. Jyoti Bhaskar, you, Dr. Raj Bokaria, comment on the termination of pregnancy. What is your policy in a patient who are FGR?
Ma'am, as far as termination of pregnancy is concerned, yes, in a FGR, more than 34 weeks, not beyond 37 weeks. That is a late onset. But yes, it all depends upon the Doppler, exactly when we are going to decide about the termination. Now, as far as the modality of termination is concerned, the mode that you're going to take for the delivery, that again depends upon a lot of factors. So whatever the Doppler situation is concerned, it's really bad. We have a very unfavorable cervix. We have got a Riker, which is less, then I definitely counsel the patient for cesarean section. Unless and until I find that the cervix is extremely favorable, it's a decent amount of weight, it's a mild IUGR, late onset, I will give her a short trial of labor by induction and then as and when the labor goes. But before 34 weeks, I always take for cesarean section.
Dr. Raj?
Same, ma'am. I fully agree with Jyoti.
And administration of steroids, it cannot be undermined. Yeah.
Oh, that's all right. Dr. Poonam?
Ma'am. Same, I think Dr. Jyoti has well said, if the cervix is non-favorable, Riker is less, no trial, nothing, सीधा cesarean कराना तो करा लो, नहीं तो जहाँ जाना जाओ.
Let me just tell you, on the other side of the table, people like me sit. Majority of the cases, the gynecologists in the periphery, they find उनको termination तो समझ आ जाता है, but वो उनको induction लेके बैठ जाती है and they lose a baby. So my advice to everybody who is going to give them a trial of labor, either you sit with them, otherwise you are inviting trouble. You are inviting trouble. Do not induce. The dictum, you take it from here. For growth retarded fetus, where you've decided to terminate, it is less than 37 weeks or around that particular time. Never ever induce these patients. Otherwise, you're going to have problems. And so extra cesarean karna zyada acha hai, instead of landing up in 1 crore rupees. This is what my advice is to all overzealous gynecologists who are for induction of labor. This is the biggest mistake you are going to do it. Small for gestational age, you can do whatever you like. But for growth retarded fetus, where you've decided to terminate on some Doppler, umbilical artery mein kuch ho raha hai, kuch hai, never ever do induction on them. That's a tip I can suggest you. And this is one of the things, I want every gynecologist who's listening me. I'm not talking about normal weight patient. I'm only talking of growth retarded fetus where you've decided for termination. आपके डॉपलर में जरा से भी हिंट मिल रही है, अभी आपका CPR बिल्कुल बढ़िया है, फिर भी मैं बता रही हूँ आपको कि आप इंडक्शन के प्ले मत करो. बैठे रहोगे तो ठीक है. जब भी पेशेंट का फीटल हार्ट अगर आप नीचे हो गया, उसको एसिडोसिस होगी और उस एसिडोटिक बच्चे को विद हाइपोक्सिया के साथ आप बचा नहीं सकते नर्सरी में. कुछ भी कर ले वो तुम्हारा पीडियाट्रिशियन. And this is what the message I want to go to you, कि कि डॉक्टर गोपाल ने क्या बोला, ये सब कुछ भूल जाइए, वो तो आपको समझ ही आ जाएगा क्या करना है, बट आपको डिसाइड करना है when to terminate and what should be the mode of termination.
And even if, ma'am, we are sitting with the patient and then suddenly we decide for LSES in setups like ours, we cannot do it we cannot take out the baby in 15 minutes. At least घंटा डेढ़ घंटा तो लग ही
You can
जाएगा.
take it from me. You can take it from me. Everybody, डॉक्टर साहब 15 मिनट तो पहले सब बिल्कुल ठीक था, 15 मिनट में ही हो गया, और डॉक्टर साहब नर्सरी में गया, बच्चे बचा नहीं सकते उस बच्चे को आप. This is what my thing is. Every gynecologist is sued for crores. So anybody who's listening us, any growth retarded fetus, if you're inducing them, you're committing problems for them. Let it be extra cesarean. Don't ever do it.
Let the patient go anywhere.
आप चाहे कितनी भी लेवल 3 नर्सरी में करोगे, लेवल 3 नर्सरी सब बेकार है डॉक्टर साहब. एसिडोटिक बच्चे को बचा नहीं सकती वो डॉक्टर साहब, बिल्कुल नहीं बचा सकते. And this is what the message we wanted to give. I think we will come down to second presentation, and I think that will be much more simpler. Thank you very much, everybody who participated. This is what the message I want to rub in people's mind, that never ever decide on the induction of labor.
Thank you so much, ma'am, all expert commentators. So we start with the second session. Dr. Krishna